Hi, my name is Jacques Dion, and I am the VP of Scientific Affairs at Microvention Terumo. I'm very pleased to introduce to you Dr. Monika Killer, Ph.D. She is a fully trained neurosurgeon who is specialized in neurointerventional therapy. Professor Killer is an attending neurointerventionalist at the Christian Doppler Clinic in Salzburg, Austria. She is professor of clinical neurosciences at the Paracelsus Medical University. She was a co-PI on the EUFRED-Study, the results of which she is presenting today. Welcome, Dr. Killer.
Thank you for the introduction. It's a pleasure for me to share our experience with the FRED Flowdiverter concerning this study that we did in Europe in the very beginning of the time when FRED was introduced here. And it was a bigger study with 15 centers. I think you're all familiar with the FRED as a stent at all. You know, it's released in 2012 here in Europe, and it is a dual layer stent with compatibility to a headway 27, and it's a nitinol braided design with an inner part of 48 braided nitinol wires, which is then the working length that we have when the stent is fully expanded. And we have an outer part, which has a high porosity stent with 16 wires, serving as a scaffold for this inner part, which does not mean that there is two stents, it's one intermingled into the other. So, but the outer part is 3 millimeters longer on each side. So you can very nicely see that here on this scheme. And you see the dense part of the stent means that is the working length, and this is the total length of the stent. So I need to share with you the participants of the study. How did we find out to do this? It was a registry in the original. And we said the first European experiences should be recorded. And we started with about 30 patients. But then more and more centers started using the FRED, and that's how it came that we got so many data. So you see there is most of the centers in Austria, Germany, but also Denmark, and very bright, big centers number. And this retrospective study, and I have to say it was all retrospective, although we collected the data prospectively. It was a post-market registry, as I said, and it included patients that were treated with the FRED between February 2012 and March 2015. And the patients had to be consented for the FRED, not for the study, yeah. And it met the requirements for the FRED treatment per the instructions of use. So that is the only thing that was an inclusion criteria to go into this registry. And the centers agreed to collect the data of all consecutive patients that they treated, at least 5. And that is how it started, but it became more than 5 for each center, as you have seen. And we had pre-printed data collection sheets, which specified the data to be collected and the study endpoints. A study nurse in my center collected all these raw data, and an independent statistician performed the statistical analysis. The vascular imaging was done at the treating center, but we asked all the physicians who treated the patients not to be the ones who evaluate these imagings and rate it, but an independent neuroradiologist in each center who was not involved into the procedure was the one who rated all these things at the final end. So we had a number of aneurysms were 579 after all these years in these centers in 531 patients, and the overall procedures were 534. You see female and male was obviously more in female patients that we used this then, and the mean age of the patients was 53 years. 26% of the patients had multiple aneurysms, and most of them came obviously in a good status, and only 1.5 had a bad status. They were the ones that were treated then acutely. And as you can see, most of the aneurysms we treated were incidental or with headache. Some had a cranial nerve palsy, and a few ones were treated with the recanalization of the previously treated aneurysm. 12% of the patients had subarachnoid hemorrhage, and 7% were treated acutely. 3.8% of the patients had a stroke, suffered on a stroke. That was the detection of the aneurysm. As you can see, the locations is that what you would expect in flow diverters. Left and right was almost the same, but most of the aneurysms were located in the ophthalmic and the paraclinoid region of the carotid artery. Some in the middle cerebral artery, some in the anterior cerebral artery, but the minority was in the posterior circulation, but at least more than 10%. We had sidewall aneurysms in 80% and a few bifurcation aneurysms in about 11%. There were about 5% fusiform aneurysms, some dissecting ones, and the blister-like ones. That was the ones that were treated acutely in most of the cases. The diameter was pretty small for a study of a flow diverter, but this was real life data. So that's what came into the centers, and the medium range was 7.6 millimeters in diameter. And the neck diameter, they were all wide neck aneurysms with 4.5 millimeters. So the number of threads used was 1 per patient. We have one patient that were 5 stents necessary, but this was a huge fusiform thing. But in general, the direction was to use only 1, and only if there is a necessity to telescope the stents, because the length at this time was sometimes not available that we needed. Most of the centers used 1, and this was more than enough to cover the aneurysms that had to be treated. These are the medium stent sizes, as you can see. And in 87% we used 1 stent for 1 aneurysm, but we also treated 2 aneurysms, 3 aneurysms, and in 1 patient even 4 aneurysms with 1 stent. A successful deployment on the first attempt could be achieved in 98% of the cases. We needed a coil embolization, or not needed, but a coil embolization was done because of the larger ones. We knew already at that time it might be an advantage to coil these aneurysms in addition. It was done in 18% of the patients. And the need for a balloon angioplasty per procedure was necessary in 2.8%, which is not very often. So the stent was nicely opening in most of the cases. The procedure time was in the medium about an hour. So the angiographic outcome, as you can see, the mean follow-up length was 6.6 months, but we had a lot of cases also more than 1 year. I will come to that later. And the complete occlusion among all these aneurysms in that time was 69% after 6.6 months, with Raymond Roy 1 in also 70%. And OKM scale, as you can see, total filling, subtotal filling, and most of the cases were also in 70%, no filling anymore. In-stent stenosis was recorded in not even 1%, and device migration the same. The complications were recorded periprocedural and during the follow-up period. And as you can see, a spontaneous rupture of the aneurysms that were treated with thread occurred only in 2 patients, and that after, I think one was after 1 month and one was even later. Spontaneous non-aneurysmal hemorrhage, was periprocedural in 3 patients and 1 after during follow-up. Strokes was in minor in 8 patients, periprocedural, and the major stroke occurred in 2 patients and some during follow-up. Stent stenosis and occlusion, this is maybe also something I might to address. Stent parent artery occlusion together with the stent occurred periprocedural in 4 cases and in 8 during the follow-up. Most of those that occurred during follow-up were asymptomatic. And as you can see in all these patients, we had a periprocedural complication rate of 4.5, including the groin hematomas, and of 4.5% during the follow-up. And we call it adverse events because this is what happens with those kind of devices. We had a detachment in the hub of the microcatheter in 2 procedures, an opening, a poor opening on deployment in 10 patients. And in 1 patient, there was a torquing of the stent on deployment, multiple repositionings in 2 patients, and of all these 500, I think it's not very often. So a total of 2.8 adverse events periprocedural, and during follow-up, we could see a fish mouthing of the distal stent, which was rated like that from the independent viewer. As we all know now, this fish mouthing impression that we had was not really a fish mouthing, but it's due to the markers on the flared ends that sometimes it looks like that. So there was not an stenosis at these parts of the vessel. There was really just the impression that the stent wasn't completely open. I think this was very important, and we learned it over the time. The mean follow-up length, as I said, was 6.6 months, and the MRS for the patients, 97 were in a very good shape, and just 1 and 1.5% of the patients did not do so well, and 6 means 8 patients died in this study. A transient morbidity was 1.9 periprocedural and 1.3% during the follow-up. Permanent morbidity occurred in 0.6% periprocedural and 0.2 during follow-up. And the mortality rate below 1%, the same periprocedural and during follow-up. Obviously, the posterior circulation was associated with transient morbidity and more often than the others. That is not something that is surprising. And the same for the aneurysms larger than 20 millimeters. So in summary, we could nicely show that most of the aneurysms were treated with a single device, the transient morbidity of 3.2% overall, and a permanent morbidity overall with 0.8% could show that in this early stage we had safe procedures. The mortality rate in total was 1.5%, and the overall complete obliteration after 6.6 months, as I could show you, was 70%, and the aneurysms that were followed more than 1 year, in this group, 95.3% were completely occluded. And I think that is what is the most important, because we could show that with 1 stent, even if we see something left during follow-up, after 1 year, most of the aneurysms are completely occluded. And this was published in HANR in 2018. And you all can see that if you want and read the details of this study. Thank you very much.
Thank you, Monika. That was great. If you have time, I'd like to ask you maybe 2 questions.
Sure.
So my first question is, how do you view the outcomes of this study relative to the other major publications on flow diversion therapy, especially the long-term occlusion outcomes?
So I have to say that we were really surprised that we had, after 1 year, such a high occlusion rate. Because when we saw the occlusion rates after 6 months, we said, okay, it's in the range how the others do. And we'll see how it occurs during the follow-up time. But finally, it turned out that we really had a high occlusion rate after 1 year. Obviously, I have to say this is one of the limitations of the study, that it was not a core lab that looked at the images. There is sure a little bit of a bias, but we had followed patients up to 3 years in this study, and once it was occluded, they stayed occluded. So the nice thing is, whoever saw these images, once the aneurysm is gone, it's gone. And in most of the cases, it was after 1 year. So in comparison, I said, couldn't have done better. Yeah.
Well, thank you for that. My second question is, how do you view the impact of this study? What does it communicate to the physician community about the FRED device?
Keeping in mind that it's not a randomized trial, or that it's not a prospective study and it's retrospective data, I think it's still that what real life is. And we all were interested and wanted to see how our data do, yeah, and how our patients finally have their outcome. And we were all interested to see the truth, yeah. And there was nobody who had to nicen the data or do something what we could not really expect, that someone gave us wrong data, yeah? And seeing that, I think it has a high impact, because this is exactly what came in. These are the aneurysms that were consecutively treated in these centers. And with 15 centers, there is a wide range of large high volume centers. And I think real world data is always not so structured as in a randomized trial, but I think that is what it is. And for that, I think we have excellent data finally. Yeah, the impact would be, I think it's good to use this stent, and I think we had really good results with it so far, and I think we still have. Mm-hmm.
Well, thank you very much, Dr. Killer. This concludes our recording. I would like to thank you, everybody, for watching.